Welcome back to another episode of Thanks for the Consult. As always, I'm Fior, and today we have Aaron with us, working on our words there still. But today's guest, we have Jimmy Apple. How are you doing, man?
Great. How are you? Thanks for having me.
Thanks for coming on. Now, I know the name Jimmy Apple might not be what everybody knows you as. Is there anything else people might recognize you as?
They might recognize me from my social media platforms, which is EMS Avenger.
Awesome.
It's interesting you bring that up because as I have gotten more popular, I get more invitations to speak at different places, and they market me as Jimmy Apple, and people don't know who that is. And so I'm actually trying to figure out a way to kind of converge those two things. There is a little more recognition to my actual name.
Makes sense. Maybe a big name tag on your videos.
Sure, yeah.
You could just say it was like sponsored by Jimmy Apple.
There you go.
No, that's awesome. You said you're doing a lot of conferences, which is cool. I know you're going to be doing one that we attend every year, so that's exciting for us to get to come hear you speak. So you, if I remember correctly, you do critical care pediatric things.
Yes, I do.
That's your specialty, right?
It is. I do neonatal and pediatric critical care transport. I also have 20 years of 911 experience and actually would love to continue to do 911 part-time, but the how to do that and with who to do that, I just still haven't worked that out yet.
Oh, that makes sense. I don't know, the pediatric neonatal stuff, that always, I'm a big guy. They're real small.
Yeah.
Logistically, it's difficult for me.
He loses them. He loses them all the time.
Sure.
But how'd you decide to transition over from 911 to the neonatal critical care?
So, after about 20 years in the field of 911, I just kind of realized that I wasn't being challenged by it anymore. I really loved the aspect of it where I was mentoring people. That my truck was usually reserved for someone who was kind of up and coming and going through paramedic school or something like that. And so, I really appreciated being able to mentor people and preset people. That's something that's meaningful to me. But as far as the work goes, at the 7,000th abdominal pain call that I was going to get that day wasn't going to be particularly challenging, right? And I wanted something to strive towards and work towards. Yeah. And I had transported a patient to our local pediatric hospital, and I was standing there, and I saw the pediatric team come in with a patient. They were in an isolette, and the patient looked really sick and intubated and on a ventilator and stuff. And I was like, man, that would be challenging, doing pediatric critical care. I wonder if that's something that I could do. And right about that time, the flight crew for that same hospital had come out of a trauma room after dropping a patient off, and I recognized the paramedic, and he came up to me, and he's like, dude, you need to be doing this, man. He's like, I could just get you right in here. And the two things just kind of converged. And so I applied, and they hired me, and I absolutely love it.
That's awesome. That's awesome. My wife was a neonatal ICU nurse for about 12 years. And she was telling me that at one point, she was a traveler for a while, and they put her in a hospital that had a neonatal ICU and then had other adult floors. It was a larger hospital somewhere. I can't remember which state, but at one point they needed to float her because apparently nobody in their float pool that day was ACLS certified, and they floated her to the ED, but it was primarily an adult ED. And she was saying that there was a lot of problems where, people were extremely tachycardic as an adult, where she's like, oh, that's fine, thinking it's a neonate and, run into problems. So I say that to say, did you have any difficulties transitioning from, 911, which is predominantly adult patients, right? Or for the most part, I'd say, to really no adult patients on a daily basis? Do you find that a difficult transition, or was it
yes and no. No, in that we have this kind of dogma that kids are not little adults, and since I've been in pediatric care, I've actually developed a keynote called Kids Are Little Adults, which acknowledges that most of what we do in emergency medicine and critical care actually just overlaps between pediatrics, adults, and geriatrics. There's very little difference in what we have to do. There's just difference in equipment sizes and medication doses.
Yeah.
But the transition was really going from 911 to full-time critical care and understanding that aspect. And I remember one of the nurses I worked with, she had asked me a question early on in my orientation, and I answered like a 911 medic. And she playfully just kind of tapped me on the forehead and said, "You need to stop thinking like EMS and start thinking like critical care." And that was kind of a shock to the system. But I found transition to kids to be easier.
Okay.
You know, adults are complicated and they're stubborn, and, you know, to be blunt, they can be jerks sometimes. And pediatrics are just not like that. You know, you can kind of cut through the chase and be direct with them, and you can be playful with them. And, you know, if a kid needs to be distracted, I can just hold up my phone and put on Bluey. You know, and I can't do that for an adult, you know.
And that works on me, actually.
Adults can be bigger babies than babies, actually. You know, I found that kids tolerate IV sticks and painful procedures a lot more than adults do. Kids have no guile within them. They're not lying to you. They don't want to be sick. They don't want to be there. They're not trying to get a free meal or a ride across town. And having that honesty in your patients and the genuineness, I think, just makes things easier taken care of.
Okay. What about dealing with the parents? I mean, does that become an additional challenge because you have all those behaviors in adults, except as an adult that's dealing with their sick child, which probably often exacerbates those types of things?
Yeah, you know, but even then with adults, you know, let's say you're having, you know, one of those calls where you're responding to a geriatric patient, maybe they have dementia or something like that, and you have to deal with their caretaker daughter or son who are overprotective over that patient, you know, and kind of consistently say, "Can you just let the patient answer?" and that sort of thing. You get very protective parents, and we just try to remember that this is incredibly stressful for them, and especially with the really sick kids. You know, the parents have lost so much control, and they're fighting for control any way that they can get it. You know, every once in a while, we have parents who make it literally impossible to take care of their patients, and you know, they won't let us do things. They won't let us get in there. They won't allow us a little bit of breathing room to perform procedures, and they can't see how they're making it impossible to care for their patients. And they actually make us afraid of taking care of their kids because of how that they will react or interfere, and that they don't realize how a lot of that control is actually getting in the way of good care. But, you know, we always remind ourselves how stressful this is for the parents. And, you know, we put our pride aside, you know, and try to just, you know, work with them to get the kids the best care that we can.
Right on. Right on. I gotta say, every time I see you on any of your videos and podcasts, stuff, you always have the coolest shirts on. Where
I
are
like
you getting these
t-shirts.
things?
I just keep my eye open for cool shirts. You know, we'll you know, be out and about, my wife and I, or something like that, and walk past a store, and suddenly I'm like, "Oh man, did you see that shirt?" And she's like, "Oh no, not another T-shirt."
I'm the same but with coffee mugs. So we have a whole cabinet that's devoted to coffee mugs in my kitchen. So if you're ever at my house, you will never be in need of a coffee mug. We have
Excellent.
plenty.
Awesome.
But so kind of changing gears a little out of order here. Tell us about you outside of the EMS world. What is, you know, what makes you tick? What makes you what keeps you going every day?
Well, unfortunately, depending on which way you look at this, EMS keeps me going, but not EMS specifically. I strove for meaning in my life for a long time. I had a very traumatic upbringing, and there was a lot of abuse in the home that I grew up with, abandonment from my parents. And as an adult, I just kind of struggled to find my way, struggled to find some meaning. I wanted to do something in my life that was meaningful. And, you know, I just kind of squandered a lot of opportunities as well. People who, you know, suffer from childhood trauma, you know, tend to be a little bit more dysfunctional as adults. And that was true for me. And when I finally kind of got things together and became more responsible over time and started making better decisions and got into EMS, I suddenly fell in love with learning, and I fell in love with teaching and mentorship. I fell in love with medicine, and I suddenly realized that I was doing something important and I wanted to impact people with that. And that does inspire me. The ability to teach
Mhm.
inspires me. The ability to heal inspires me. The ability to learn inspires me. But outside of that, I have three wonderful children, three grandchildren, and it's,
Wow.
amazing to have, and I have a beautiful wife, and it's amazing to have, a family, where there's, mutual love and affection. I'm inspired by traveling. I love to travel,
Okay.
and EMS, as content creator and educator, getting to speak at conferences, that feeds that love. I get to travel all over the United States. I love to hike, and I love to do particularly challenging hikes where I get to scramble and really like wear myself out and climb and stuff like
Okay.
that. And I am a voracious reader. I read anywhere from 80 to 100 books a year.
Wow.
Maybe a half of that is like educational type stuff where I'm reading, smaller books on different subjects, but I love sci-fi and fantasy and classic
Yeah.
American literature. And so I'm always in a book somewhere.
That's awesome. That is awesome. So you've been a mentor and an educator for a while, it sounds. What advice would you have for you know aspiring preceptor mentors, aspiring or new educators,
Or old ones.
to kind of, or old ones? Yeah.
Yeah.
Huh.
Sure.
I guess any
Well,
any of them.
to start with, I would say that if you don't want to be a mentor preceptor, you can say no. That's the most important thing. Um,
Yeah.
I think that if you are a grounded individual, you see the need to precept and mentor, and you see how important it is. But not everyone has the gift of it. Not everyone still has the energy or the time or the patience for it.
Yeah.
And there is a time and a place for everything. And if this is not the time in your life for precepting or mentoring, you are allowed to say no to that.
Yeah.
It's not good for anyone if you're doing that and drawing from a well that is empty.
Yeah.
But that leads me to my second point, which is that as a mentor and preceptor, you need an inflow and an outflow. If you only have an outflow, you're going to be empty relatively quickly, and you're not going to be mentoring appropriately. So you need to be mentored, and you need to be mentoring. So there needs to be a very careful balance there. And another thing is that you need to remember that what you're doing, I'm not very religious, but there's a Bible verse that says, raise your children in the way that they should go.
Okay.
You have to identify what that person's strengths and weaknesses are, recognize that they are not necessarily your strengths or weaknesses, and that your strengths or weaknesses are not necessarily those. And
Yeah.
you're not trying to clone yourself. You are trying to bring the best out of the person that you're mentoring, enhance their strengths, mitigate their weaknesses, maybe teach them some things that are your strengths and weaknesses, and kind of supplement their strengths and weaknesses, but you're not trying to make them into what you are.
Yeah.
And they have to have the ability to fail without feeling judged by that. And they need to know that. They need to know that they can fail and get it wrong.
Yeah.
Um, and in some cases, there are, we talk about the eating their own and kind of like the negative attitudes and the toxicity. There is a time and a place for a righteous anger as well.
Oh, absolutely.
But that is very, very targeted in a very, very isolated instance. But for the most part, it should be all rooted in kindness.
Absolutely. I guess I teach paramedic programs in Pennsylvania. And one of the things that I've found is towards the end of the program when they're going into their internship or, field internship or capstone, whatever you guys call it, the last bit of hours where it's basically that preceptor's there to just kind of watch and make sure you don't kill anybody, but you're
Right.
running the call, you're doing everything. I've had students that are like, "Hey, can I do that with you?" I'm like, "Absolutely not. You've listened to me for the last year. Go learn from somebody else at this point and, find another way of doing things because I do things a way that works for me. That may not work for you at all, but for me it works. Go learn another way. You've learned the stuff that I have to tell you. Go see what they can show you."
Yeah. You actually raise another point, though, that I want to emphasize, which is sometimes being a mentor is recognizing that you're not a good mentor to that person, right?
Yeah.
And actually identifying someone else who can help them.
Yeah. One of the nice, so we have in our area a lot of agencies. Like we don't have a county agency. It's each municipality has, their own. There might be one service that covers a few municipalities or towns, but for the most part, it's, in our county, I think we have 38 currently services. But it's such a small community still. And one of the things I like is, hey, I'm going to precept at service XYZ. Like, I know somebody there and I'm like, oh, you need to go, do ride time with Aaron. He's going to be really good for you because he's doing this or that, which I like. But are you guys more county based or are you guys more local for your
We're a
911 services?
hospital-based system.
Oh, okay. Just for the whole area.
Well, there's a children's healthcare system in Atlanta.
I mean, for your 911, it
Oh,
county
well,
or
where I worked in 911, it was a private service.
oh, okay.
Yeah,
Very cool.
that served the county.
Yeah. Right on. Yeah. Interesting. So
I'm
currently I work out of a health system and Aaron works for a private service that covers half of a county,
Mm-hmm.
which
It's crazy. I have 4 years of experience, and I just got named the manager the other night.
I mean, I'd like to pretend to act shocked or something like that, but if the lifespan of the average EMS individual is less than 7 years, then people are going to be promoted to managers in less than that time. So
Yeah.
yeah.
Well, I can tell you, I'm
and
terrified
the question
and
is
intimidated.
not the time and rate. It's just, what's your skill set? There are people that are just know how to manage people. It's something that they understand. And so, after 4 years, if that's something that you're already good at, there's nothing wrong with that.
I appreciate your vote of confidence in me. It is falsely placed, but I appreciate it.
No, Aaron, you downplay yourself. You're a smart cookie. You'll figure it out. But no, but Jimmy, you're right, absolutely, with the average lifespan being so short. And in his situation, the director resigned, and Aaron was the only other supervisory personnel at the time, and I mean, kind of until they officially made him the acting director or what have you, it was hey, by the way, you're it for now because
Yeah,
it's like war rules at that point.
sure.
Yeah, absolutely, it happens. I saw that early in my career. I was telling him last night that the first 911 service I worked for, I was there for 9 years, and I had at least 5 years of tenure on anybody there whose last name wasn't the same as the owners. So you kind of very short lifespan at some of these places, which is another question that I guess, asking somebody else who's been around for 2+ decades, how do you think we as EMS can improve the lifespan? I mean,
Well, I think we're starting to see how that happens, and it's really by opening up other areas of healthcare to paramedics. Somebody had asked me the other day about what I thought about a paramedic. They were working, I can't remember what environment they were working in. Like, I think it was in a blood donation center or something like that. But I was like, I'm
okay.
all for it because there's no upward mobility in 911. You can become, you'll have a service that has 200 people in the field and maybe 4 supervisors, and so where is there to go? There's
Yeah.
nowhere to go. And so only by opening up other areas of healthcare to paramedics are you going to start having more and more opportunity.
Yeah.
So, I mean, that's really where, that's going to go, as we start maybe looking at kind of like the paramedic practitioner and stuff like that, we might see some expansion there as well.
Are you excited about that?
Yeah, I think that's great. I mean, I'm all for it. And I think it's necessary. I think that there needs to be kind of a mid-level there for the field that can help with the kind of the the disposition of patients.
Something that I've noticed is like EMS providers tend to talk about themselves, and I think accurately so, as being misunderstood by the healthcare system, right? And people don't
Sure.
actually understand what they can do. But I feel like, a lot of the physicians, particularly on the emergency side, do actually have a pretty good idea of what we can do, and there is enough understanding of it. But there really still hasn't been much movement to allow paramedics to really utilize their skills in the way that they could be able to. Even in hospitals, sometimes it's difficult, when they're working under an ER department. It's for them to be allowed to do things that they're good at. I mean, there's paramedics who could go into ER who would have more innovations than any physician in there, depending on what they
Yeah.
do and where they work. I was just curious if you had thoughts on that, why that is, how to fix that, because there's a lot of paramedics who I think feel unappreciated because they can't actually, it's hard to find meaning whenever you feel like you can't be used.
Sure. There's a lot of layers there to peel back. I think that the healthcare system kind of generally understands what paramedics can do. The problem is they don't know what their paramedics can do. And paramedics don't even always know what they can do. I have been talking a lot about whole blood on ambulances over the last week because I attended the Midwest Whole Blood Summit, and I had active paramedics in the comments saying, well, that's just against our scope of practice. We can't even do that, not understanding that 42 states allow for paramedics to administer blood, and over 300 services have blood on their ambulances. And so we have a very compartmentalized educational standard. One state, a paramedic in one state doesn't know what a paramedic in another state can do. A paramedic in one state can perform intubation with paralytics, and a paramedic in another state can only place an iGel. A paramedic in one state can do a surgical airway and a resuscitative hysterotomy, while a paramedic in another state can only form a needle cricothyrotomy. So there is so much disparity in what we can do that the people who are in definitive healthcare don't really know what their local people can do. And then when it comes to something like the ED, there is a lot of politics involved there too. There are nurses there who have degrees, who are able to do an awful lot. And when the paramedics come in there, there's an identity crisis because they're not there to be a nurse. They're there to fill in margins between all the scopes there. And there are people who have specialties in those areas. A paramedic is very versatile, but they're not experts in intubation. Even paramedics, who intubate regularly in crash airways are still not intubating as much as, an attending in an ED, who is, performing intubations in crash airways a couple of times every single day in very difficult airways and with lots of different tools. So, it's great to have that utility, but we have experts in the hospital to perform specific things. And I don't know if we necessarily want to bargain ourselves out of leaning into the experts in those specific areas. So it is very complicated and very political.
Yeah. I to add to that, I would think that another kind of restrictive factor that we have as paramedics is we're largely out of sight, out of mind kind of thing. And a lot of what we do is out of necessity because, we obviously can't put, a cardiologist, an internal medicine, anesthesiologist, a nurse, all of these different specialties inside of an ambulance and show up at your house, right? That's just too many people that logistically wouldn't happen.
Right.
So we have to be able to be proficient in all of these different areas. And there's certainly, just with anything, there's certainly a differing level of proficiency and skill level between, the two paramedics, 3, 10, 20, and it just kind of gets bigger and bigger. But, we're they don't see us until after the things have been done. We're coming into the hospital, what have you. But, human nature being what it is, you remember the screw ups more than you remember the guy that rolled in and it was like, yeah, no, everything was fine. The airway was secure, the IV was in place, the medicine was given, and the patient's doing a lot better now. And it's just, you remember the guy that comes in and he's tripping over his his stretcher and
Sure.
the
Just dumped the
patient.
17th liter of normal saline into the trauma patient.
Exactly.
Yeah.
I mean that's the one that sticks with you, unfortunately. But I agree with your point, and I think part of it too is we're not in those arenas often enough. Like I know when my wife and I first started dating, like I said, she's a nurse. She had no idea what we did. You know, she was familiar with they have the service similar to you that shows up with a paramedic, a nurse, and then somebody to drive to transport patients in or out of their NICU in the isolette, and but kind of no real understanding of what I do out in the field, running 911 calls. And just the same as I have a vague understanding of what you do, right? But I certainly couldn't jump onto your truck and be useful as a participating crew member without a
Sure.
lot of extra
Yeah.
onboarding and training, I'd imagine.
Yeah, we have an advanced pathway we put you on before,
Yeah,
you actually just start getting in there and intubating babies. But
yeah,
we have to remember that what we're doing in the field, the model is essentially to perform interventions that have the greatest amount of reward with with the smallest amount of risk. And we are rolling the dice a little bit on some of that to ensure that we get people to the hospital alive.
yeah.
And it's often a salvage operation, and they give us some pretty incredible things to do,
Oh yeah,
but a lot of the decision making has been taken out of it simply because if I don't do this, they'll die. Like if I don't put this breathing tube in this patient, they're going to die. Whereas in the ED, and in a ICU environment, or critical care environment, there is a lot more to it. Like when
yeah,
we have to intubate someone, it's not just, okay, let's just tube them and we're just going to use ketamine and rock and that's it.
yeah,
We have to ask ourselves, what is the pathology here? We do an ISTAT, and we look at their gas and we look at their labs. We get, you know, CMP, CBC, and all this sort of stuff from the facilities. We look at all of their lab values and all that sort of stuff, and we make decisions based on a lot of information. We look at a patient's chest X-ray.
yeah,
Sometimes we'll put a patient on positive pressure because they may, have some sort of some sort of cardiac defect, or they may be so sick that they experience some sort of cardiomyopathy, and we want to be careful about putting positive pressure on them. And there's discussions about what sort of medications to use, whether we should use ketamine or not, because they may have some sort of adrenal insufficiency. All these things go into the discussions in the ED and all of these interventions. And a lot of paramedics tend to look at this simply as, I can do that thing,
yeah,
but they haven't necessarily been trained to do that thing considering the entire clinical picture.
yeah,
And so that's why there needs to be more education in that regard. And I think there was even a proposal to create a hospital certification for paramedics.
yeah. That's so. I mean, kind of to your point there. So I think my busiest year of intubating, which is a hot topic, I guess, was 26 intubations. And but you look at these docs in the hospital, that's a month or less, you know.
Sure.
Um, but if you talk to some other people, 26 is an obscenely high number of intubations for a year.
I've
Just
not
kind
even
of
seen
depending.
26 innovations in my 4 years of EMS.
But so the health system I work for, we do every 6 months they put on an advanced airway lab with cadavers, and it's excellent program, and we're only allowed to go once every 2 years because we work there. But I went a year ago, I think, and I was talking to some people in there, and they're like, "Yeah, I haven't intubated anybody in 15 years." I was like, "Oh my gosh, that is scary,"
But
because
they probably complained that the eye gel sucks.
probably I
I
can
love
tell
the
you,
IGL.
I
I
hated
do
the
too.
eye gel until I realized that when they came out, the service I was working for, we had the uh, tube tamer that could take the eye gel or the ET tube. And once I started using the eye gel with the straps like the elastic straps that were made for that eye gel,
Hmm.
my complaints certainly have died down because
I
that
have
was my
a
biggest complaint was it would dislodge during transport.
I have an
Yeah.
unpopular opinion that I'm curious what you think about. So a lot of people, that is their complaint about the iGel, is the lack of security with it. Where I work, I'm lucky if I have, another crew to come assist me, let alone another paramedic. So usually it's just me. So if you're on a cardiac arrest, there's a lot to get done. Probably don't have an advanced EMT with me either. I've got a lot to do. Easier to use an iGel. Well, who often ends up, being in the position managing that airway is an EMT. And just unfortunately in my area, there's not a ton of training, not a ton of experience. What I like about the iGel is that if you're not getting a good ventilation, you might just need to push down a little bit more. Like the fact that it doesn't have to stay exactly in spot, you can kind of just put it in, generally speaking, and you can manipulate it. And it would be very easy for an EM2 holding a BVM attached to the iGel, just kind of push up, push down. Um, it's something that I now don't have to pay as close of attention to while I'm prioritizing other things.
Yeah, there's definitely a learning curve there, and most of the problems with the eye gel just come with securement. It's just a securement issue, and so a good securing device will help. And also being aware that you have to be aware of what you're doing. We tend to get people who, are bagging, but they're bagging, but they're not necessarily paying attention. And so there's a lot of movement there. And so they're kind of rocking the eye gel back and forth, but wondering why there's air leak. And so, yeah, a little bit more downward pressure, makes all the difference.
Yeah. Yeah, I do like to give Aaron some of the business for not intubating, but that's more just because I like to make fun of him.
And even paramedics who have, let's say you have 70 intubations in a year, how many of
Mhm.
those are in cardiac arrest that aren't particularly challenging? And,
Yeah,
you don't feel the pressure. I mean, if somebody's,
right.
performing compressions during the intubation, you might prolong the attempt a little bit until you get it. And you're not really
Yeah,
thinking about how challenging that was and how challenging it would have been done to do that to someone who was actually peri-arrest
yeah.
and knowing that you literally have seconds to do this before they experience cardiovascular collapse. So, just intubating in cardiac arrest doesn't, even if you did it 50 times that year in cardiac arrest, that is not the same thing as like
Yeah.
a difficult airway intubation.
Oh yeah,
Mhm.
I 100% agree with you there. That they are two very different skill sets.
Yeah.
Even though it seems the same, it's very different skill set. But
Yeah.
If I
um,
might change gears here a
yeah,
little bit, Jimmy, I love to ask people this question, just because in EMS everything is extreme, and so you just often a good answer to this question. Do you watch sports? Are you a sports fan?
I don't have time really anymore. I grew up a huge baseball fan. I grew up in the tri-state area, and my family were Mets fans, but we were just baseball fans altogether. And so we would go see the Mets and the Yankees and the Phillies.
Mhm.
I watched the NFL for a long time, but once my kids were getting to the age where they had to be places, I just couldn't anymore, and I just never really picked watching it back up. But I still like baseball. I just really don't get to follow it.
So there's a phrase in sports that they talk about. Oh, it's like your welcome to the league moment. Have you ever heard of that?
Yeah.
Yeah, I'm just curious. What was your EMS welcome to the league moment?
Well, my very first call in EMS as a student was a cardiac arrest. And it was with the person who I considered a mentor and just a rock star paramedic. And I had never talk about being exposed to skill and patient management and crew management. This guy was a 3-tool player or a 5-tool player if you're talking baseball. So it was an elderly gentleman who experienced sudden cardiac arrest. They were sitting at dinner, him and his wife. He was in his 70s and he collapsed. We get there and, we're working the code. And then we kind of hear someone just go, "Oh, oh," and we turn around and his wife collapses and goes into cardiac arrest. And people were freaking out. We're
yeah,
getting, calling for another unit on the radio. But this paramedic acted like he expected it to happen. Like he was just like, "All right, get a second set of pads from the." He talks to someone. Oh, I remember what he said. He says, "Hey, everyone, can you match my energy, please? Okay, can you just match my energy so we can do this? We can't have people panicking here." He pointed at someone. Go get a second pair of pads from the truck. Someone goes and gets the second pair of pads of the truck. He directs someone to start compressions, and then he just timed his rhythm checks or his pulse checks, rhythm checks between the two patients, just kept switching them between the pads. And he was performing defibrillations, and we were timing drug delivery between the two, and he made it work until the second unit got there. And that was my welcome to the league moment. It was an incredible example of someone's being calm in the middle of chaos.
That's amazing.
And I had to do something like that later.
I have to imagine that had you had a different preceptor who was just losing their mind, it might have been your first and last day.
Well, it's funny because I had another preceptor who I didn't work with after this day, but who had a kind of a freak out moment on a call. And I, after having been exposed to that first preceptor, I'm like, I don't want to work with this other preceptor. They have bad habits and they don't manage themselves well. That's a preceptor who should have
Chuck Norris
said no to precepting. What's that?
You met the Chuck Norris of precepting. Anybody after that was going to look bad.
Yeah, absolutely. Yeah.
Yeah. Wow. I mean, before this story, I thought I had some good preceptors. Now I'm questioning everything.
Yeah. The biggest takeaway I had from there was the match my energy thing. I've had a couple of calls where I was like, hey, folks, can we match my energy here? Okay. We have to make some good decisions here. So let's just match my energy.
Oh, yeah. It is interesting to one of the more difficult things that I've found is when you're on that critical call is you're trying to manage the patient and calm the crew down at the same time. It's like, okay, I can do one of these things proficiently. If you guys could calm yourselves down, I'll take care of this until you're ready to jump back in. That'd be great. But I definitely struggle with trying to calm people down in a nicer manner when it's like, guys, this patient's going to die if we don't get ourselves under control.
Sure, yeah. And sometimes it's about calming the crew down because they're just creating a bad situation. I've had plenty of calls where you've had patients who weren't the most cooperative people, they didn't have the most pleasant personalities. And we don't have a lot of good training in de-escalation in EMS, and we tend to actually match energies with patients or escalate. I mean, I can remember several times where another responder on scene was going toe to toe with the patient. I had to be like, hey, I'm the one who has to get in the back with this patient, and you are creating a terrible situation here, and you could even be making it unsafe for me. So controlling energy is very important.
But yeah, I think the people that I see that brag about how many times they've had to sedate a patient, I'm like, yeah, you're doing something wrong. Cause I think I could probably count them on one or two hands over the last 20 years that a patient needed sedated for safety concerns.
Sure. I mean, we've all had to do it, but yeah, I mean, I think there's a lot of patients that we could probably take the energy down and they would be safe to transport.
Yeah.
It's funny that we don't talk about the tact as much as we should for a provider, just because, I've seen very different approaches and I've seen them be successful, and it's very hard to know what works. I've seen people, patients kind of being tough with you and maybe a little bit snippy. And I've seen people, just kind of very firmly say, we're not doing this. You can stop that. And, for me, that wouldn't be my first instinct at all. I'm very much it's okay. Calm down. Like, I'm a de-escalator, but I've seen that be more effective at times than people who are just like,
absolutely,
doing that. So it's funny to me that we don't talk about that, because that's something that could be such a useful skill for providers.
Absolutely. That could be an entire series, about de-escalation and the tact that you said. You definitely have to be tactful. And there are times where you simply can just starve the patient for energy. Yeah, we're not going to do that. You could literally say that, or you could just not give them the energy to bounce off of, and it basically just kind of suffocates the moment, But the most powerful thing that I think a clinician can do to just let the air out of the balloon is offer an apology. And that apology is not an admission of guilt. It is not saying that you did anything wrong. It is an act of diplomacy. Like, hey, you know what? However we got here, I'm sorry for how this is going, and whatever my part was in it. Can we just can we wipe the slate clean here, because I just don't want this to keep going this way, and we just need to go in a different direction. You can phrase it however you
Yeah.
want, but a well-timed apology can often just take all the air out of the balloon. And not only that, but it's good damage control. Like, I can't tell you how many times, I mean, I make it sound like this happens every day, but I've had a couple of moments, where it was a ready, fire, aim moment for me with a patient or a family member, and I knew a phone call was going to come after the fact. And I just went up to whoever it was and just said, "Hey, this is my supervisor's number. I recognize that didn't go well. Please call them if you need to give feedback." And that call will probably never happen after that.
Yeah. Well, yeah, that's a great point. But it also, I think the words that you say are far less important than the tone that you carry them with in the de-escalation. I mean, obviously, you, you can use insightful wording, but if like there was a guy I worked with that he would he would say, "I'm sorry, but," and then like just berate them for 5 minutes at the top of his lungs. And he's like, "I don't know
Yeah.
why they're mad. I said I was
It,
sorry." I was like,
it's like saying, with all
"Well,
due respect, what's coming
yeah,
after that is not good.
yeah, not to be mean, not to be racist, not to be, insert," and then you do
Oh my God.
the exact opposite of. I'm like, yeah,
Sure.
I don't think you can just excuse all of your poor behavior by saying, "I don't know why they're mad. I said I was sorry."
Sure.
Like,
Yeah.
I
I
think a
mean,
lot of times people just want to be
one,
heard too. Like, we don't ask them
yeah,
why they have the opinion that they have. And whenever you just say why and you just try to get to the bottom of it genuinely, people, and then you can explain to them why the difference of whatever it is that you're talking about is there and why you want to do what you do. I tell people, because I work in a very, very rural area, where 45 minutes to a hospital is no long transport for us, and I say to them, you have a very unique opportunity where these people who are chronically ill go into hospitals all over the time, where they're constantly faced with different providers who don't have enough time for them. And those people would probably like to have the time for them, but they don't. You have 45 minutes alone in an ambulance with this person where you can allow them to feel seen and heard and actually have a positive experience in healthcare. And you might gain a bit of knowledge or information that might inform the hospital that actually might help them come to a diagnosis, prognosis, whatever the case may be, quicker. Like, take advantage of that. Don't sit there and just worry about doing your chart the whole time.
Sure. And we have to remember, I think that's a great point. We have to remember too that we get so many patients that have chronic illnesses, that have people that have to assist them with their daily lives to greater or lesser degrees. And those could be physical illnesses, they could be, mental illnesses, they can be patients who are not well adapted or well adjusted. And the people around them become kind of noseblind to all of that, and become a little bit hardened to the daily struggles that they experience. And, maybe someone who experiences chronic pain, where today they just, even though their pain management regimen may be keeping them from being an extremis, they still are experiencing pain on a daily basis. And the mental toll that can take on someone is overwhelming, but the people around them are becoming tired of hearing it. And not with any malice or anything like that. It's just human nature. You become a little bit hardened to someone's daily pain, and you're a fresh set of ears for that patient. They just need an outlet for whatever's going on, and just talking them through it, you can be an incredible part of that person's day, if you can just have two sets of open ears.
I think
yeah,
they
oh,
feel that they're
absolutely.
never going to see you again. And I don't think they feel that way about the people in the hospital. So I think the patients tend to be so open with us, almost to a point of like scary clarity and transparency, where I'm like, I didn't
Yeah.
need to know all that.
You with them long enough, you get all the family drama going back generations.
Sure.
But yeah, I don't know why. Back to something you said about giving them the supervisor's phone number. Have you seen that video that's been circulating TikTok? It's the lady's. It's for some grocery store. I don't know which one, but she's bringing it back. She's like, "I bought this cheese and there was a hair in it," and the lady behind the desk is like, "No problem, we'll refund you." And the lady with the cheese is like, kind of looks defeated, and she's like, "But did you want to fight?" She's like, "Yeah, kinda." Just like took the air completely out of her sails there. But I think that's probably the same thing. Like, hey, here, call my supervisor. I know I messed up. They're like, well, all right, I don't need
Yeah.
to anymore. But I mean, so that's a pro move right there, I think, you know?
Well, it's giving them some control back, you know?
Yeah. Oh, absolutely. Absolutely.
So I got another one
So,
for you. That was your
okay.
welcome to the league moment. What is your favorite like old head medic trick, right? So like I've asked people this question before and they're like, I love to put a cannula on because you can put for somebody that has an eye injury that needs irrigated, you can put a cannula here and start irrigating saline through it and it just sits there. And I love hearing what people's like, oh, this is the thing that I found out one time that I thought was so cool. I tell everybody about it.
Just a
Well, mine
disclaimer, we are
actually,
working with Aaron on not calling me and our guests old, but
No, it's
we're
just
not
it's a
doing
term.
that.
It's like it's an old man trick, you know? It's the wisdom.
I
The
mean,
wisdom trick.
I've felt old since I was 20, so it's fine. Um, Mine actually does involve a cannula. So, you know, we get a lot of patients that we have to intubate and there's secretions, they have a contaminated airway, and trying to tape the tube on someone that's just wet and gross and nasty, you know, is like an exercise in futility. So you can take a nasal cannula and you put it over the patient where the prongs are over the mouth. And then you take the tube and you put it between the prongs and you take the tube and tape it around the prongs. And that creates a natural friction point where the tube won't slide up and
Mm,
down and the cannula will hold it in place.
Yeah,
I
that
love
is
that.
good.
I love the
Yeah.
ingenuity because like that's what a lot of EMS providers take pride in. Is like, oh, we do what the hospital does without all the, safety nets and, we figure stuff out, make it work type thing. So I love to hear the things that people come up with and how they figure out how to do stuff.
Yeah. Here's another question that
I'll give you a legendary answer to that
yeah.
though, and this is not medical advice, but it's just somebody found a solution to their problem. So I worked at a service, this rural service, this one old timer, older than me, who sucked at intubation. He just sucked. Like he just did not have the dexterity at all to be able to do it. And he just was constantly missing. And this was back when all you had as a backup was the comba tube. So it was like a disaster
Mm.
for him to miss, you know? And then suddenly his competency turned a corner. And I asked him about it because we just couldn't believe it. Like he went from hardly being able to get a tube unless, you could literally just tilt the patient and see the cords without a laryngoscope to suddenly, an over 90% competency. You know what he was doing? He
Not
would just
documenting
blindly
misses.
insert the tube. And if it went into the esophagus, he would leave it there and insert the next tube. It wasn't going to go back in the esophagus. And to this day, I don't know if that was terrible or just freaking brilliant,
Yeah. I mean,
Dior gave me the same advice the other week. I told him about how I pulled a tube that went into esophagus. He's like, just leave it there. Put the other one in. There's only one
Right.
spot left for it.
Right.
It makes sense. I mean, anatomically speaking, unless you're going in upside down with a major hook, you're going the right way. There's only one pathway left,
Right.
So
This is something I've
One-
personally struggled with a decent bit just because of being in an area where there's not a lot of paramedics. I'm now the manager of a service with 4 years of EMS experience, 2 years as a paramedic. I by no means, am a highly skilled paramedic by no means, that I need more time. And the shame of it is that there's not a lot of opportunity now for me to get mentorship and just, the same way that if you had worked on a truck with a double medic service in a city, you'll be with another paramedic and you'll see him do something. You'll go, oh, that's a great idea. I don't get exposed to that nearly as often. So I try to talk to people and ask people stuff because I just don't, I feel like I'm missing something with that.
Well, your job is to keep the trains running on time, though, right? I mean, not the training officer, right?
I was the training officer, actually.
Oh, okay. Okay. Wow.
Yep.
Okay.
That was my promotion from training officer to manager, and now there's no training officer. So I guess
Gotcha.
I'm both still.
Okay.
Kinda,
Well,
yeah.
Godspeed.
So we have a little debate here on the show regarding IVs.
Okay.
Are you a self-occluding or non-self-occluding guy?
Well-
all things equal, you can pick what you have. You're both sitting there. They're both clean. They're both working. Which one do you want?
I actually had made a video on this a couple of months ago. I mean, I learned on the brawn,
Okay.
and that's just where the muscle memory is. And so if you put, anything else in my hand, like the one that has the chamber in it, and the little button and everything, it just feels so much different. And the analogy I give is that I had my gallbladder taken out probably about 20 years ago at this point, but they go in laparoscopically, and one of the areas that they go in with that laparoscope is in your belly button. And once it healed over, my belly button felt different. And every time I would, like, you do your little belly button check for lint or whatever, and every time my finger went there, I was like, it's not my belly button. That's how I feel when anything other than that brawn gets in my hands. I mean, I can
Okay.
work with anything, but this is kind of my preference.
Fair enough. Fair enough. It's a weird belly button fact. I don't have one.
Really?
Yeah, I had diverticulitis that ruptured, and they had to do a ton of surgeries. And I had 7 surgeries. Through 6 of them, I had a belly button. The 7th one, they sewed it shut. I was
I
like,
mean,
I almost made it with one.
I would, I would, I would be, if that had to happen, I'd be like, that's fine, but then take the nipples too.
Yeah. But no, it's weird because like you still get like that phantom sensation to like check it for lint, and I'm like, there's nothing there. I don't know what's happening.
That's funny.
So the IV catheter debate here is that I personally like a non-self-occluding catheter. And the reason being is because every time that I try to use a self-occluding catheter, I'm not making this up. I would say 50% of the time, it does not occlude. And so if I have to guess whether or not the device is going to do what it's supposed to do, I would rather just use one that I am planning on that happening rather than thinking, oh, this is going to occlude and then doesn't, and now blood's everywhere because I thought it was gonna.
Yeah. Yeah. I can see that. Yeah. I mean, if it's not delivering on its promise, then yeah.
Yeah. I still
Plus, it's
think
kind of like driving
error.
a manual. You know what I mean? Sometimes it's just like you like how it feels to do it the old-fashioned way.
Aaron,
Sure.
can you drive a manual transmission?
Yeah.
Yeah, okay. Here's an interesting thing. I just kind of, speaking of IVs. So I know a lot of IVs for neonates they're not secured with tape because their skin is very fragile.
Mm-hmm.
So I know like long-term care, they're sutured in at times, things like that. What are you guys doing if you start an IV on these neonates? Are you suturing them in? Are you kind of wrapping them?
Well, we're doing it in the field, and so we do use tape.
Okay.
But we use very specific, we use the type of foam tape that comes in the start kits. But, as far as like what they do in NICU or anything like that, I'm not exactly sure.
Yeah.
I'm trying to think. I actually can't think of a transport I had where they had a taped IV catheter.
Yeah.
Once they get to that point, they're probably not leaving the unit wherever they are.
Yeah.
So we don't see those patients very often. So it's the ones that, when we start in the field, we usually are taping them.
Yeah. So I'd imagine the ones that are super long term are getting PICC lines or central lines put in. They're not changing IVs out every, couple of days. So that makes sense. But so when you started the transition over here to the pediatric or the neonatal critical care, were you already a critical care paramedic, or did you have to do that and then kind of get into learn the critical care, then learn the neonatal and pediatric specific stuff?
I had critical
well?
care experience.
Okay.
I took our in-house critical care program where I was.
Mm-hmm.
Which was a full critical care program, 80 hours, I think.
Okay.
And then I did work adult critical care. I worked 911, and they would pull me off of that for critical care transports. And so, and I was on a mobile ECMO team where we would, for 3 different hospital systems. So our service would go grab the perfusionists, and we would go to an outlying facility where the patient would be cannulated by the team. And then, we would manage that patient on ECMO back to the home hospital. And so that was some pretty awesome critical care experience. Some of these patients were really sick. They were on VA ECMO. And that was some great critical care experience.
Yeah. It sounds like you guys, you have done a lot of really cool things that I'd imagine most people don't even know are options for a paramedic.
Yeah. There's not a lot of the kind of like the remote cannulation team thing happening. I mean, it's happening more often, but yeah.
Mm-hmm. What are your thoughts on the mobile like the mobile stroke units that you can do the scan in the field and the radiologist can read it remotely. Because I see them
Wouldn't
in
we
the
all like a vacuum cleaner that sucked up money?
yeah. I mean, my thought is I see them in large cities where you couldn't swing a dead cat and not hit a hospital.
Yeah.
And I'm like, well, that'd make a lot of sense where Aaron's at because, he's got a 45-minute ride to a hospital. At least they could maybe get some stuff started there.
Well, and we have to
Or,
make the decision a lot between whether
yeah,
we're going to fly or take him because they're all primary stroke centers.
yeah,
Sure. I mean, I think from in a generalized sense, it's a solution in search of a problem.
I like that.
And yeah, I particularly because there's still even debate on the utility of TPA. You
Mm,
know, so the notion that okay, we're going to get you to TPA faster now, or
yeah,
TPA to you faster, and in a suburban metropolitan environment, like what are we even doing here?
yeah,
And we're starting to see now also that you can administer TPA even further out. There's
yeah,
been studies coming in that you can. You have to establish a couple of things at a baseline, but we're starting to see that the window can be extended considerably for some patients. So I don't know. In some rural environments, maybe there's utility if you can get it there fast enough,
that
and you don't
becomes
have
the other
HEMS or
problem.
anything like that. But outside of that, just don't think from a cost benefit analysis that the utility has been established.
I would agree with you on that. I was like one of those things I like to get somebody else's input on because I've noticed whenever there's innovation, if you're like, it seems kind of silly, it's kind of demonized a bit. Where there's certainly I don't know how much one of those trucks costs, but it's got to be close to 500,000 or more. Uh,
It's
you
more than
know,
that.
yeah,
Um,
like you could
and it's
do a
the sort
lot
of thing
more.
where EMS services are not looking for those.
No,
Like, they're not like, we need a stroke ambulance. It's more like, we want to give you a stroke ambulance. And they're like, oh, okay, sure. That's cool.
yeah, I'd rather them pass out whole blood and the coolers and the
Absolutely.
freezers or the packs
Yeah.
and
Why don't you pay for comprehensive training for a cruise for 5 years?
mhm. You know how many new paramedics we could get through school, fully paid
Right.
while in school, pay for all their tuition. Uh,
Yeah. Paid to get everyone trained in like
yeah,
doing the NIH exam, instead.
yeah. There's a
There's data
lot
out
of
there that says that we miss a ton of posterior strokes simply because we're not performing the types of exams which would catch a posterior
I
stroke.
tell everybody about that because of your video. I just want you to know that.
Oh, nice, nice.
50% of them, isn't it?
Actually, I think it's around 75%, but yeah,
shit.
I've been underselling it.
yeah.
Man, good thing you're not getting commission off it, Aaron.
We had yeah, thanks for the consult. Do not accept endorsements, financial gifts, donations. That was my
Yes, we do.
disclaimer. Oh, okay.
We're not going to tear away money.
Jimmy, how'd you
No,
get into doing social media and stuff like that? Was that something that you always wanted to do, or were you just like, I want to pick up my platform and continue to do training for a larger audience of people?
I around the time that podcasts started to become popular, like Medic Mindset's like one of the big podcasts that was starting to get popular, and Tyler's at the time I think was called Lifestar before it became Foam Frat. Those podcasts were starting to get popular, and I wanted a platform, and I wanted to do something forward facing where I could do more than just like teach on the truck. I wanted to teach on a larger platform. And I actually became friends with Ginger Locke, who is she's the one behind Medic Mindset, and told her that I wanted to do that. And she introduced me to Tyler as well. And Ginger was like, here's the thing though, what are you going to do that others are not doing? And I didn't have an answer for that. I had to concede I would just be doing what you're doing, but like less good.
That's our whole motto here.
So what I did was just work social media for a while. And I started to become known on social media. I would follow the the more popular people and contribute to discussions. And like even like Kelly Grayson realized when my EMS Avenger channel became popular that he was like, oh, this is a guy that's been commenting on my stuff for a while. And then my daughter started sending me TikTok videos that they thought were funny, and I could never watch them because it kept prompting me to install the app. And I'm like, I don't want to install the app. And then one night I was like, okay, because they were bugging me. And I was like, fine, I'll install the app. And I was like, you know what? I bet you that like half of EMS is on this all day long.
Yeah.
And, you know, maybe some of these people aren't keeping up on their learning at all. They're not getting any new information. I was like, I think that I could just like sneak some information to their feed once or twice a day. And that maybe that would, I think that would make a difference. I think that would be something worth pursuing. And it took off immediately. So, yeah.
Well, I think one of the things that I've noticed about your platform versus some of the others, and there's, I'm not saying that yours is the only good one out there. Yours is very good. There's a lot of people putting out education, and I'm like, where are you getting your information? Like, this is insane.
What I like about you is there's no broad generalities. There's the education is specific. Whereas I feel like is that where you were going with that feel? Whereas I feel like there's a lot of people who are like, well, in general, this is what you should do.
Well, but like everything you post is, you know, hey, I've put the links to the studies in my bio, and verify me, fact check me if I'm wrong. I want to know. And it comes, it's truly educational, and I've never once watched one of your videos and thought, man, he's arrogant. You know what I mean? Like it's like this guy is just.
It's funny because I've gotten that feedback.
How? It's truly.
I think earlier there was some arrogance there, and you know, I had to monitor myself and be objective about myself and listen to other people's feedback. And I agreed in watching back some of the videos. I was like, oh, that was arrogant. You know, and I'm committed to getting the data to people, and I'm not committed to my ego. And so, you know, it's easy enough to take the L, you know, when you're not getting your message across. At least it is for me.
Yeah, I mean, I've never seen that one though. But no, I would say your content is truly educational, fact driven. I just you've found a very good level, keeping, you know, there's some humor in them. There's some great information, and it's backed by fact and science.
I like that you respond directly to criticism too. You know, you respond directly to people who comment something. They're like, well, what about this in regard to whatever topic you're speaking about? And then you address it. You know, a lot of people, that turns into an argument in the comment section, or they don't completely address it. For me, as someone who's consuming the information, it's just awesome to be able to go, oh yeah, I don't know. What, is that a problem? And then see your response right there and see how you address it. I just think that's an awesome thing.
I think it's important to stay engaged. I think it's important to not leave people hanging. Now, I can't get to as many comments as I used to be able to. It's just, I would be just all day in the comments. But I try to get to some of the important questions and stay engaged. In fact, I can remember when I started getting popular, someone told me one of the reasons why they liked me was because of the engagement that I got in the comments, that I talked to people that I didn't really like. You know, it wasn't like your typical internet fights. It was just, you know, I continued just to present the data. But to me, the way to protect yourself from your own ego is to make it about the data, right? And not to live and die about whether you're right or wrong. And, you know, there are some great educational creators out there. And, you know, I follow some of them. And there are some that maybe don't have the time and rate that they need to. I would say that they don't know what they don't know right now. And that can be a little scary, because what they're teaching is what they learned in school and not necessarily what they have taught themselves based on the most up-to-date information. And that can be dangerous, because then what you're just doing is that you're making dogma easier to understand, which is, you know, that's not what we want. Well, so, yeah.
And the data changes so rapidly. I was telling Aaron, you know, when I went through EMT class, we weren't allowed to check a blood sugar, and pulse oximetry was optional. Like, you know, and now they're able to give nebulized albuterol and in our state. So we're in Pennsylvania, which we are probably one of the slower to adopt new protocols, procedures, medicines, but they're given epi no longer in the EpiPen. They can draw it and deliver it IM. Um, the AEMT or the EMT intermediate, depending on your state, has been adopted in Pennsylvania. Which the irony of that was it was partially developed in Pittsburgh, the curriculum, and then we were like the last state to adopt it as a scope of practice.
Yeah. Home of Freedom House.
Yeah. Oh yeah. 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 So it's crazy when you think of where we're at. A lot of medical innovation has happened here, and then they're like, it's for everyone else, not you.
Right. Right.
So, but no, it changes so quickly. So, if you're relying on info you got 5 years ago, even, it could be, yeah, no, that, eh,
And if you're not
good at the
constantly
time.
reading, you can
Yeah.
find yourself to be way behind in the data.
It seems like
Yeah.
a lot of information in EMS is passed through old adages, GCS less than 8, time to intubate,
Yeah.
and
Sure.
like those tools can be useful. I don't want to say that they're completely useless. I mean, I'm sure there's times where they're helpful, but that's what I really appreciate about your content is that it doesn't feel like, oh, well, here's a generality about, well, if they're GCS, I can think of many times where a GCS was less than 8 and that person did not need intubated,
Yeah.
Um, and so I think that that's what I just really enjoy about your content specifically is it doesn't feel like that at all. It's very specific. Here's what you should know. Here's what we are pretty confident about. Here's where that could potentially take us. And I feel like I've been given a very broad understanding of that concept in general. You know what I
Yeah.
mean? And people
I
don't
think
talk
it's
about that
important for
stuff.
us. Yeah. I think it's important for people to have rationale for what they're doing and to break through dogma. We're becoming more sophisticated. People want to do more stuff. They want to have more pay, but with great power comes great responsibility. And,
Yeah.
you need to have a more sophisticated understanding of pathophysiology and data if you want to do more stuff and you want to earn more money.
Yeah.
And I think it's also important to democratize EMS. There shouldn't be academic gatekeeping. We should be letting knowledge flow down to everyone so that they can be better at what they do.
Absolutely. Absolutely. I couldn't agree more. But one of the things I don't remember what in the last couple of sentences struck this for me, but the amount of people that as GCS less than 8 Unibate. Sorry. In classes, it's like, we're doing a scenario. It's like, okay, why would you do that? I don't know. Okay. Well, am I wrong? I didn't say you were wrong. I'm just asking you why you're doing it.
Mhm.
You need to know why you're doing things. You can't just blindly do things.
Yeah.
Or you're going to be wrong at some point.
I can remember as a paramedic student with another one of my preceptors, we picked up someone who they knew them as a frequent flyer. I did not know them as a frequent flyer. And I started an IV on this patient, which made it so they couldn't go to triage at the time. And my preceptor asked me, why did you start an IV? And I was like, because protocol. And he was so disappointed in me. It was the only time I ever felt disappointment from a preceptor, and it really impressed upon me, the necessity of having a rationale for what you're doing.
Yeah. Well, I work on we call it a response unit. Some places call it a chase unit, a dart unit. I ride out by myself and intercept with different crews. But the amount of times where, I'll show up to complete a crew or with a BLS crew and, it's a BLS patient. And my mentality is, you called me out here, so you weren't comfortable with it. I'll just take it. I'm not going to belittle you or make you feel bad about it. But I was with a service. I was completing a crew. I guess they had split their crew to assist one of their other ambulances. So it was EMT only on their truck. So I'm completing that crew for a very minor crash. The patient just wanted checked out at the hospital. No problem. Vitals are all fine, everything like that. I said, do you want to ride this or do you want me to ride it? Like, well, I think you should ride it. Hey, no problem. So they have the intercom system in their truck. When I called the hospital, give report it, it's like, hey, this is a BLS notification. I have this, this, and this, and they like get on the intercom, like, it's ALS. I said, well, just because I'm back here doesn't mean it's an ALS patient. All I've done is monitor vitals. I've not started an IV. I've not given medications. The, so, but I very well could have just. I guess I'm back here. I'll start an IV. I guess I'll do a 12 lead, even though there's no indication that that's needed. And what I mean, I think understanding why you're doing things is so important. So you're not subjecting patients to needless treatments and medications. And, an IV is, we're not sawing off a limb, but it's by no means a completely painless procedure. There is
No, and
some
I've seen
risk
many people
involved.
start, have 3 attempts on someone they were getting an IV on for no particular reason. Like, why
Yeah.
are you doing that?
Yeah. Yeah. I mean, if I really need it, I'm going to keep trying. But if it's just, they'll probably do it at the hospital. They can do it at the hospital then, you know?
Yeah, yeah.
It's-
So
but
one of the things that like EMS providers I think have a unique skill in is like the sixth sense almost of like just being able to walk into a room and have a gut feeling about I don't know why yet, and I don't know if I can articulate it, but this is what I think's going on. This is what I think's going to happen, and being right about it frequently. I'm curious if you think that that is just a person who is able to identify signs and symptoms who can't quite articulate the pathophysiology for what they're seeing, or if that's almost an intangible skill where it's like for some reason you have an ability to be able to walk in a room and really just your first couple thoughts of your differential diagnosis are just you're going down the right rabbit hole.
I think there's a little bit of both. Like you paid attention, in your education, and you are able to take that, even though you may not be processing it like deliberately processing it, but also reading people. I think that, there's an intuition there. And I remember in school them talking about paramedic intuition and hearing academics affirm that there is a certain intuition. Some people have it and some people don't. I remember, a lesson I learned in trusting my own intuition. We were called to a chest pain call, and we were flagged down on the road leading to the chest pain call by this car that wouldn't let us advance the flag. They flagged us down and said they were the ones who had called. And the husband got out and was like clutching his chest. And I'm like, this guy is having a STEMI.
yeah.
I just knew it. I just knew that he was. And we were right down the street from the local community hospital that did not have a cath lab. I did the 12 lead. There was no ST elevation, nothing to indicate that he was having a STEMI. He wanted to go out of the county to where the PCI was. And I was like, you're not having a heart attack, so let's just go to the community hospital. I convinced him to do that, despite the fact in my gut, I knew he needed to go to that other hospital. We took him to the community hospital. They did a 12 lead. ST elevation 2-3 AVF, reciprocal changes in 1 and AVL, reciprocal changes in lead V1, V2, and V3. He was having proximal RCA occlusion, and we had to be the ones to transport him from that hospital to the other hospital. And I had to look him in the eye the whole time and say that I messed up. So I learned to trust my intuition. But
Yeah.
conversely, I had a partner who was a newer paramedic, and I can remember being on a call where a patient was having some neurological symptoms and was hypertensive. And I knew this patient was having a stroke, but they didn't seem to catch it. And I wasn't quite catching that they weren't catching it. And so, I was asking them, hey, do you want to, because it was my turn to drive and their turn to be in the back. And I was like, hey, do you want a rider? And, they were just looking at me like, why would I want a rider? And I was like, okay, do you want to go license sirens? No. And after the fact, we talked about that. They just didn't pick up on the subtleties, and I knew it immediately. And that doesn't mean I'm not saying that I'm a better clinician or that they were a poor clinician, but some people can pick up the signs just on first glance, and some people can't.
Yeah. Well, I think a lot of it comes down to pattern recognition too. Like you've probably saw part of that, if not all of that, on another patient. previously.
Sure.
But I think there is too just that, like you said, Aaron, that sixth sense, that intuition. So I remember when I was precepting, we had a patient that came in as general weakness, and I don't remember specifically the vitals, and I was like, I think that they've got a bleed. I think they've got a brain bleed. I think it's slow, but I think they have a bleed. And they're like, can we go to the local hospital? And I told my preceptor, I was like, I think we need to go downtown, which would be where the trauma centers are. I think they had a bleed. They're having a bleed. And they're like, I don't know, and they're like, you know what? I'll let you run your call. I'm like, all right, cool. So I tell them like, listen, we need to go downtown, blah, blah, blah. And we get them down there, and sure enough, they had a slow bleed that they'd fallen a day or so earlier and didn't tell the family members. And they cracked their head off of the fireplace, the hearth. That's what it is, the hearth.
Hmm.
And I to this day, I can't tell you what made me think that. It certainly wasn't skill at that point. You know what I mean? It was absolutely just something is telling me this is what this is. I have no, I can't tell you why. So there's something to it. I think
Yeah,
it's,
absolutely.
you just kind of get that feeling and go with it. And I've always been one of the ones I would rather take you to the further hospital if it's more appropriate than have to come back and get you, because I'm going to feel embarrassed walking back into that ER. Be like, yep, I'm here to collect my mistake and move it. Thank you.
Yeah. I'm a big fan of taking the patient to the hospital that they should go to.
Okay.
In the Atlanta area, we have like 10 hospitals within our 285 perimeter,
Okay.
and people, the politics of the transport decision. I mean, I can remember hearing one crew after another over the radio, we're en route to X hospital, which would be farther away, and they'll add the caveat, patient choice. Basically, they're telling everyone in the world that they are protesting this decision, that it wasn't their choice to go to a farther away hospital. Like, every hospital should be the patient's choice to begin
Yeah,
with, unless it's not appropriate. But
sure.
the
Especially if
other
you're
thing,
that close.
yeah, I mean, it's going to take you longer. You're going to go through traffic or whatever, but you just got to do what you got to do. Particularly with kids, and we see this all the time. We have 2 children's hospitals in our region, and people will bend over backwards to not take the kid to the children's hospital, and all they're doing is just making it another cruise problem 15 minutes later. To me, I just felt like that I was giving myself a gift by not protesting their hospital choice, that just going where they needed to go just made my life easier.
Yeah. So like our area, we have one children's hospital. But there's like in the northern part of the county anyways, I believe there's one in the southern part. They have like a certain times that some of the community hospitals will have a pediatric physician on. Um, but the problem is you don't know what those times are. And what does that mean? Did they bring in enough of the, size appropriate equipment? Is it so if somebody's like, yeah, I'd feel more comfortable if they went to children's. Okay. Let's just right down the road. It's an extra, 15, 20 minutes, but uh,
It's not something I
you're not
struggle with
going
because
back.
your closest one is my closest one. We live 2.5 hours away from each other.
Fair enough. Yeah. So, I mean, for you, it would make more sense. But for me, it's like, it's 15 minutes. Just go down to the right hospital. But I don't know. I recently started doing more rural stuff, and the amount of stuff that people fly out of convenience is appalling to me.
Yeah, we
Like,
have a helicopter, and it's, we get totes just like ground units do.
mhm. Well, I had a crew that I was intercepting with, and I was like, "Hey, what do you guys need?" And they're like, "Nothing. We're just going to go to the LZ." I'm like, "Oh, what's going on with the patient?" Like, "Oh, has some rib pain." I said, "Okay." Like he wants to go down to the city. Okay. Well, I'm off in 30 minutes. I'm like, that is absolutely insane.
Yeah. Like, how many HEMS crews did we lose this year from crashes?
Yeah, that's. I mean, and even beyond that, 10 minutes later, there was a rollover with entrapment, and they're screaming for multiple helicopters in a different part of the county. And I was like, well, would have been nice if the closest helicopter was available, but it's on its way down to the city because you get off in 30 minutes. Cool.
Have you ever
Yeah.
seen a helicopter turn into a patient refusal?
I've heard of it once, and
Uh,
I've seen people call them off as they're on final, but I've never seen the helicopter crew get out and take a refusal.
I
Have
think
you?
we, I think we've had, I think we've had one recently, and it was a big deal. We were all talking about it. I may be misremembering this, but I know we've had one.
I mean, I'm shocked that you guys have that paperwork on the helicopter.
Well, it's on the tablet.
Okay, perfect. Aaron, have you seen that? Is that
I've heard stories. I've heard stories.
okay?
That's all. I haven't seen it live. I just think that has to be the craziest. Me as a EMS provider trying to explain having just imagine the idea of a flight crew landing on the ground and then the patient being like, "Yeah, I don't really want to go to the hospital," and then having to explain that to the flight crew is just absolutely mortifying to me.
Yeah, I think
I
it
think
had something to do. I think this is actually a while back. I think it had something to do with the family member finding out they weren't allowed to fly with the patient
Mm,
and shutting the whole thing down at that point.
okay. I've seen a few where like we've a couple of my coworkers we've canceled helicopters because it's a crew calls for a helicopter. You get there and you're like, they think it's a stroke or something. It's like, hey, what's their blood sugar? I don't know. It's like it's 30. Let's
Right.
check that out. Let's fix that. And oh, now they want to refuse. Okay. But and I think a lot of it is people don't know the capabilities of their closer hospitals. And like I had an open femur fracture the other day, and the fire department was asking to put helicopter on standby because it was a block from their fire station. They beat me there by 15 minutes. And I get there, and I'm like, okay, what are the vitals? Like, what's going on? Like, what? It's an open fracture. So I get that, but like, what are the vitals? You get there, the patient's fine. This guy was like, yeah, I'm only in pain when I try to move it. I'm like, yeah, let's not move it that for now. But you know, he, we were able to take him. There's a lower level trauma facility that was 30 minutes down the road from there, and they were able to take care of him. He didn't need flown into a level one facility. Um, but I think a lot of it is people just don't know what the local facilities are capable of. Um, and I think a lot of it is they had a bad experience with that hospital once 20 years ago, and I'm never taking a patient there.
Sure.
So I don't know, but yeah, we've been going for a while now. I apologize, but
It's fine.
this has been really awesome getting to talk with you, pick your brain. You're a wealth of knowledge, and I think both of us could I could say this for both of us. We're big fans of what you're doing. Really
Thank
appreciate
you.
that there's somebody like you out there doing educational content that's real, factual, and kind of pointing people towards the science. And it's like I said, it's been awesome getting to talk with you, and we're genuinely appreciative of your time. Um, you know, and I thank you for the consult, man. It's been great.
Absolutely. Thanks for
Just,
having me. I really appreciate it.
yeah. Is there anything you want to plug? Any of your upcoming speaking engagements? Anything like that?
Let's see. I'm not speaking, but I'll be at NAEMSP in the end of January. The National Association of EMS Physicians, they're gathering, and that's so I can cover. There's a whole lot of data that is unveiled there, and
Mhm.
abstracts and stuff. So I'll be covering that. My next speaking engagement will be in the beginning of February, and that's in the local Metro Atlanta EMS conference. And then I'll be in McKinney, Texas later that month for the All Star EMS conference, and then I'll be at a conference in February in Hot Springs, Arkansas. And
Man,
then March is a busy month too. I'll be in Chattanooga and then Oregon and Western Pennsylvania.
that's right. Well,
Yeah.
we'll have to catch up in person up there.
Yeah.
Um, as we all say around here, we'll see you on the mountain. Um, for that conference, it's a good time. But yeah, I for all of you guys watching, listening, what have you, definitely check him out. If you're able to get to any of those conferences, guarantee it's going to be an educational experience. If you haven't, check him out on his TikTok and other socials. Absolutely worth the minute of your time to watch those videos and learn something new for sure. But thank you. Thank you again.
Thank you.
Thanks, man.
Any final words from you, Aaron?
Thank you. This was cool. I geeked out.
Absolutely.
All right. Well, thanks, guys. We'll see you all next time. If you're interested in being on the show, reach out. Thanks for the consult at gmail.com.